Welcome to the Morgan Medicare Minute. I am super excited for another episode here tonight in Denison, Texas at Podcast on Main. And I have two very incredible special guests. I have waited a long time to talk to these friends. And I have with me Jolene Sinek. And she is a social worker. And I've got Connie Spears, who I've known for 30 years or so. And I just met you, Jolene.
Yes.
And her and Connie work at a local hospital, and I'm super excited because we're going to get to talk about the options of Medicare and how they navigate the healthcare system. So I'm a broker, licensed insurance agent, and so I'm the one opposite of you now. I used to be where you are, and I used to be in the healthcare system as an occupational therapist, but I'm on the other side now. And I'm the one that helps people choose the most appropriate option for their healthcare needs when they get into Medicare. And then you guys on the other end are I call you the front lines. You are the ones that take that plan, and when you have a sick person and you are essentially finding the care that they need and helping them navigate. So as you're finding their care and what they need, you're dealing with their insurance plan. And there are two options of a Medicare plan. Someone gets to choose a Medicare Advantage or stay with original Medicare and choose a Medigap to fill in the gaps or what Medicare doesn't cover, and a drug plan and so on. So what I want to talk to you about is I want you to give me your take on how someone navigates the healthcare system. Let's talk first, I guess, and this is totally unscripted, everybody. We don't know what we're going to say, but it's all going to be good. How does it look when someone navigates and they have original Medicare and a Medigap plan? And they're in the hospital, because you guys are in the hospital setting. Okay, so I'm going to let either one of you take this.
So as a physical therapist, from day one when the patient comes in and I see them, we start discharge planning. So we have to start deciding, is this patient going to be appropriate to go home, or are they going to need further care after their hospitalization? So a lot of times they do need some further care, and depending on what plan they have, honestly, is what we end up choosing for the patient. Our professional opinions, we do take those into account. We do put those down. But if we know the patient does not have traditional Medicare and we want to send that patient to an inpatient rehab facility, we know the chance of that patient getting into that rehab facility, no matter what their diagnosis is almost next to zero.
So what you're saying is if they have original Medicare with a Medigap, there's a better chance of them being accepted into an inpatient rehab.
Correct.
Where they can get 3 hours of therapy a day.
Correct.
7 days a week versus going right to the skilled nursing.
Yes.
Most people, from back in the day, and I know y'all are you would want to go to the more aggressive therapy setting so that you can recover quicker.
Yes.
Getting that hands-on. So you're getting some. So tell me what the difficulty is. If it's easier with one option, having original Medicare and a Medigap, what is the difficulty when someone has an Advantage plan?
An Advantage plan, frankly, is a disadvantage in our.
Okay, so that's good that you say that. So tell me from your perspective, not mine as a broker, but what's your perspective on that?
So what we run into is I have a patient, therapy recommends rehab, and they have an Advantage plan, and we know it's not going to happen. We have to have the conversation with families about we need to probably pursue skilled, because we are fairly confident, 99% confident we're going to get that denial. And if we had traditional Medicare, it's not a question. We just choose which one do you want to go to. We make the referral. We're done.
Do you think that is a decision based on cost?
100%. Yep. And, we deal with a lot of people who live on fixed incomes. And so if something's going to save them money in the long run, and, it comes down to sometimes, do I get my medicine or do I get my groceries? I mean, so it makes sense why they choose the Advantage plan, but I don't feel like they always have a good understanding of it, because they tell me, well, yeah, I have, whatever Advantage plan, but I have Medicare.
I have Medicare. That is the big thing. And so
they have no idea.
That's where I get the referrals from you guys to say that, because this person doesn't understand what they have. And so just to kind of explain it, kind of how I explain it to people is an Advantage plan is a Medicare replacement, like and it is with an insurance company. And we're not going to name names or anything like that, but it is with an insurance company, and it has the benefits in it of Medicare A, hospital, B, doctor visits, D, drugs, and then anything else. But what people don't realize and they're not educated on is that there's networks that come with this Advantage plan. It's structured real similarly to a group health plan, where you have networks of doctors. You can only go to those doctors in the network, or maybe pay a higher price if you have a PPO. You have to stay in the network totally if you have an HMO and have referrals. But there's co-pays for everything. And there's a maximum out of pocket to meet. So whereas it looks like sometimes that you're saving money, initially with no premium, you have to approach it from the catastrophic illness perspective. And I guess coming from healthcare myself, that's how I paint the picture. Now, some people right off, I know that they're going to be fine on it. But when I put someone on an Advantage plan, I also put them on a cancer plan. And I also put them on an indemnity plan to help them, because people don't realize there are co-pays that come with a hospital stay.
And I think what you said, the catastrophic illness, I work in the intensive care unit. I see people every day with a catastrophic illness. And unfortunately, we see a lot of frustration. Typically, the patient isn't understanding at that point, but the spouse and the adult children just don't understand. They don't understand the difference. And I've even had people pull out their Medicare card and say, look, I still have Medicare. And I have to explain to them, no, you didn't. When that company called you and you agreed to change, you gave that up. And so now you're part of an insurance company. And they had no idea, because it's also listed as a Medicare. There's a Medicare something plan that it's listed as. Like
it's a Medicare Advantage. I have seen it worded in some employer health plans as a supplement. You cannot call a Medicare Advantage a supplement. It is there's two separate things. And so people, you get the terminology incorrect, and so it confuses the issue of what actual plan that you have. So have you seen, being in the ICU and a social worker, have you seen denials in the ICU? I mean, ICU is like
constantly. We're fighting
for more days.
No.
For more days, or?
Well, I don't work in the part where we're submitting for the hospital stay, but I have coworkers that do, and there's some Advantage plans that they make it really hard to get approved in the hospital. We get denials all the time, and then you move to my role in doing discharge planning.
You may want to push your mic up just a little bit. Yeah,
and it's a constant fight, and family will know we still want rehab, so we'll pursue it. We'll get the denial, and then we'll pursue a family appeal. And there was a time where the family appeals would get it turned over, and now we get denied, and then we're left with, what do we do from here? And
well, does the patient incur all the cost if they need to stay, want to stay, and they're absolutely getting a full out denial? And I know this has happened in like skilled nursing, where they have to sign a waiver and that they incur all the cost if it gets outright denied.
That I can't speak to. I think there's a path for them to pursue. And I know that our case managers who work in that part of it are constantly, they have their protocols and processes to hopefully
So
fight
they're constantly
that.
fighting.
Yes.
They're constantly, so it's
All angles.
constant. So
Constant.
that is the Advantage Plan route, when you're actually using it. So when someone is not using the Advantage Plan in the healthcare system, then, those low premiums kind of come into play. But what you have to do is you have to paint the picture. If you do get sick and you use the hospital, this may be the navigation that you're taking, a stop and go.
And I think it's important for people to seek out professionals like you to paint that picture for them, because people think that they know. They watch the commercials and they get the brochures and they read through it and they think they know the answers because they're educated people. These are retired business people. These are educated people.
Smart people.
But it's very difficult to navigate, and these companies know how to word things to persuade them to go with their insurance company instead of going with traditional Medicare.
And there's not, and I'm going to say this, because I have to play both sides of the fence, being a broker myself, but I've honestly had some good experiences. So I want to give you a happy story on an Advantage Plan. On every Advantage Plan, in a case of emergency, like if you're outside of your territory, because these are very territorial specific, and I had a client of mine who went to visit her children in Boston. I believe that's where John Hopkins is. And anyway, she had a fall, major fall, resulted in surgery, resulted in rehab, and the family, I believe, called me every day in a panic because it was an HMO. Is my plan going to cover me? Is my plan going to cover me? Well, we did a lot of coordination. I coordinated with the case manager. I got to talk to the case manager. I talked to the insurance company. Because it was in the emergency, life or death, we got that everything was covered as in network. She was on an HMO. So her bills from that hospital stay and rehab all matched up with, and it was very stressful. I'm not going to tell you. It was very, very stressful. And she did get denied for rehab. But like you said, we fought, and the case manager did a lot of the fighting for it. But we went back and forth on what they should do. And luckily, I had put her on that summer an indemnity plan, and so she was able to file a claim on that plan and get reimbursed for all those hospital stays, co-pays. So that was a beautiful situation. Stressful as all get out getting there, but it ended up good. But back to what we really need to do is educate.
Yes.
Absolutely.
Educate the children, and you're never prepared.
No.
Right off. In a catastrophic event, and you can't think straight. I will tell you, we've all been there in the hospital, sick, and nobody can think straight.
Yeah. And I think nobody expects it. You could be a healthy over 65 person and you think you're never going to need it. You're never going to fall. You do these wonderful things for yourself. You're healthy. You walk 3 miles a day. I see it all the time. And there's just accidents that happen.
Yeah,
and
trip on the sidewalk, break a hip.
They tell me all the time, I never thought this would happen to me, but something is going to happen.
I think, too, consumers, beneficiaries are not educated, and you got to find the educator out there, and to know what kind of questions to ask. If you're dealing with another broker, what kind of questions should you ask another broker to make sure that you really, truly understand the plan that you're getting? And I think the biggest key is to understand how it covers you in a catastrophic situation.
That's a good point.
Not when you're healthy. There's not a plan for the healthy and a plan for the sick.
So we see a lot of frustration too, especially from family members when they come in and they say, well, what can we do? And so one of the things I say is, open enrollment. But I learned from you can't always switch from your insurance policy, your Medicare replacement policy, back to traditional Medicare. I thought you could. I thought you could change during open enrollment, which is in October.
This is a great segue into this because are you on Facebook, Joel? You're on Facebook. Yeah, we're all on Facebook, okay? So the same publication gets shared all the time.
Yes.
I don't know who made it. It wasn't a carrier. It wasn't, and it's very biased. Okay, we know that, and but it's misleading in the fact that under certain conditions, can someone go back to original Medicare if they've been on an Advantage plan? Take your patient in the ICU, for example. If they have a long list of diagnosis and medication and they've been on Medicare for a while and they want to go back to original Medicare, yes, I can put them back in original Medicare, but they would not qualify for a Medigap plan because at that point they have to be underwritten.
Yeah. So
And
they would be responsible for the copay and the cost then after that.
Yes, there's a 20. So if I just put them on regular Medicare, or they chose to do that in a drug plan, which they could, and they did not qualify for a Medigap plan, they would owe 20% co-insurance without a limit. So when you're talking, I always say heart attack, stroke, cancer, dialysis, any of those, that fit that bill, then 20% without a limit, it could break your retirement completely.
So if someone has been in our ICU and they've had a catastrophic illness, based on they have that diagnosis now, they probably can't go back to traditional Medicare because they wouldn't be able to get the Medigap to cover the 20%.
You do not want to put them on regular Medicare with no protection.
Oh, goodness. Okay.
And so I'm the bearer of bad news.
Yeah.
As an occupational therapist, I was the bearer of bad news to say, you have to take up all your rugs in your house, I am, but I'm the bearer of bad news. A lot of times when I say, Mr. or Mrs. So-and-so, I cannot, or I'm talking to the children and they say, we want to go back to original Medicare. And I'm like, okay, tell me about your health. Let's talk about that. Let's talk about what you need and that sort of thing. It's not about money at this point.
Right.
It's about the care that someone needs. And so I have to tell them, I'm sorry, you will not qualify. The only thing that I can do as a broker is change from Advantage plan to Advantage plan. And sometimes that does not fix the problem.
Right. Because I think they're all in a race to be the worst. And that's just from my perspective.
That's okay to say
I know
your
that sounds horrible.
No, but it's okay.
I feel for these people because you watch the commercials. You want it. You want to sign up for that because it's great. And I just think they do such a disservice to people because not everybody, while we do encounter those who are smart and are, have a great understanding or a grasp, we've got a lot of people whose health literacy is so poor. And so they're at a disadvantage. And I feel like the Advantage plans, the only advantage is they're getting people on their plan, and it benefits them and not the patient. Now, I heard your story, and I know there are those.
There are some good ones out there, but
I have a family member who has an Advantage plan, and I cringed. But in their situation, it's actually worked really well. So I recognize that it can work really well, but we see more often than not all the barriers that get put up, and it's heartbreaking when you have to stand there, and as you well know, when you're telling them they can't go back to traditional Medicare, when I have to stand there and say, I'm sorry, there's nothing more I can do at this point.
Right.
And you feel horrible because you know you would want the same for your family member to get them what they need.
Right.
And I can't do it with Advantage plans, but with traditional Medicare, from the hospital, from the ICU, I can get them exactly what they need for their recovery.
It's a smooth ride.
It is.
And that's kind of how I describe it. It's a smooth ride. An Advantage plan can be stop and go. Yes. And I have had some horror stories and I've had some good stories. But for me as a broker, I have to sit there and across from someone and I have to look in their eyes, or I have to look in their eyes on Zoom, or hear it in their voice on the phone that I have to educate every little detail of that Advantage plan and paint the picture. And if they are still okay with it, then that's what we'll do. But I will protect them on the back end or recommend that they get these other policies to protect them.
And I think that's, that's the benefit of someone like you. You will do your due diligence. You will make sure that they are well informed to make that decision, make that choice. Whereas I think others, if they get that phone call and they answer it,
they're shiny objects. It's all in the wording, like you said,
and you get sucked in, and then you have no understanding. And then one of the things that, and I'm sorry, I'm getting on my soapbox, but
it's okay. I want you to.
That we run into is you tell families, well, we can't do X and Y, and they're like, well, I just called the insurance company, and they told me blah 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 blah. We can do this, this, and this. Well, you're speaking to somebody who's reading from something that says, yeah, of course, we cover rehab.
It's like a script.
It is.
It is.
But we're communicating, or the rehabs that we're working with, they're communicating with a whole different department. One has nothing to do with the other or understands what the other does because they're in their zone and they're doing their job. But families look at us like we're nuts. And we're like, I'm not lying to you. I'm just trying to help you understand what we're up against. And
yeah, it's, it can be very difficult in a catastrophic situation to understand that. But I want to talk a little bit about, because we have the annual enrollment coming up, and I want to do a whole show on that, because what can you do during the annual enrollment? What is it for? Basically, because y'all are going to get hit with it.
Yes.
And doesn't communication kind of rise up, during that time with your patients, or, change? Like what kind of happens from a healthcare perspective during the annual enrollment, which is October 15th through December 7th?
I honestly haven't really noticed a whole lot during open enrollment because people don't know what that is. They're not even educated on what that is. They just want to know, this is the plan I have. I was denied rehab, or I was denied certain pieces of equipment. I've even had trouble getting people equipment. So what can we do about that? So then we tell them and we educate them about open enrollment. And I've always told them just switch back to Medicare, but I can't tell them that anymore.
But if someone, if they've had a recent hospital stay, no, I can't do it.
Right.
But okay, so here's what I'm going to give you some knowledge here of what you can tell them. So the ICU, you're probably dealing with a long diagnosis that you can't reverse, okay? Right. So let's say someone comes in and they've had a hip replacement or a total knee, and they're a year, or let's say down the road, okay? They have an Advantage plan, but down the road, as a therapist, that they're going to recover. You can see the picture when you walk in the room of how that person's going to live and their recovery, and they're healthy. You can see their history. So, down the road, what you can tell them is, say, you won't qualify now because of this one event that you've had so recently, but down the line, give it a year, give it 2 years. With your picture of health, if you stay healthy, yes, it's a possibility that you could probably get to original Medicare with a Medigap.
And so we have
people, give them a little bit of hope.
Yeah. And so we have a lot of times in ICU, they end up going on dialysis temporarily. I heard you mention dialysis earlier. So if they go on dialysis temporarily and they do get kidney recovery and it's a year down the road, is that a better for them, or because they have that?
It depends on how their total picture of health.
Okay.
I'm going to send to you the kinds of health questions that they ask, and I think that will give you some good insight to who may qualify down the road.
That would be good.
Yeah, that would be good for all the case managers to know that, or social workers. You're a whole group. I think you're all one.
We are.
Anyway, I don't want to differentiate between the two. You all work together to get people from point A to point B, but there are questions in their time. They have time frames on them. Some of them have in the last month, in the last 6 months, in the last 2 years, in the last 10 years. So some of them go back. Some of these questions go back in the last 10 years. Some of them I have come across, have you ever at any time? So then that knocks some people out too.
So are these questions specifically, because they can go back to traditional Medicare, but these are questions for the supplement
These are
policy.
questions for the supplement.
Okay.
And in certain states, there are, so somebody can change a supplement. People want to change a supplement or if the premium gets too high too. So some states, not Texas, have a birthday rule and an anniversary rule. Birthday rule, they open up about around 60 days, 63 days around your birthday. You can change no health questions asked. And then an anniversary is around the anniversary of when you first got the supplement. You can change with no health questions asked. But Texas doesn't have that. So anytime you want to change supplements because of a high premium during any time of the year, not just the annual enrollment period, you have to be underwritten.
Okay.
They're going to ask about all body systems.
I see.
They're going to ask if they use a walker, wheelchair, anything like that. They're going to ask if they have dialysis. They're going to ask about your heart. Are you categorized as heart disease? You know, if they have an aneurysm that they're monitoring, any stents. I say, I'm sorry, I can't do it.
But aren't all these questions pre-existing conditions that I thought didn't count against you?
Good segue, because when you're first on Medicare, when I say that, I mean when that person is first on Medicare Part B, the part that you have to pay for, 6 months from that date. So let's say I start Medicare August the 1st. I have 6 months from August the 1st, full 6 months, to get a Medigap with no health questions asked, guaranteed issue. So I can have cancer and I can get a Medigap. I'm not going to be asked any health questions. So it's automatic. But 6 months down the road, if they want to change to another Medigap, they have to be fully underwritten. And change from an Advantage plan to an Advantage plan, they don't ask any health questions at all. But going from Advantage plan to a supplement or a Medigap, and I use those terms interchangeably, then you're asked health questions.
So that's why it's important in Texas to find someone like you to find the correct supplement, because basically in Texas you're on that for the rest of your life then, it sounds like. Unless
you're healthy.
Unless you're healthy and can switch from supplement to supplement.
Yep.
Okay. Do you happen to know about Oklahoma? Because we get a lot of patients from Oklahoma as well, being so close to the border.
I think they've got, I don't do a lot in Oklahoma. I have some, but they may have a birthday rule. I'm not sure. I'd have to actually check on that because I don't do a lot of birthday rule at all. But they could.
Yeah. And every now and then we do get people from out of state who are visiting. And I think we've had issues with them needing further care, and we've had to get them healthy enough where they can fly home to get to a facility at home.
Yeah, depending
on what they have. So
on the Advantage plan?
Yes.
Yeah, because they're county area specific.
Yeah.
So they want you to get healthy.
So you could have a company in our area with one name that only does certain things with certain doctors, and go to Boston and it's the same company name, but it's a whole different plan.
There are no national Advantage plans.
Okay.
There can be national networks.
Okay.
So like if you're out of your service, if you're going to take care of your mom in another state and you have an Advantage plan, you can actually, if you're going to be gone for an extended time, I think you get a year outside of that service territory, you can access in-network doctors, but your plan is not there.
So what defines healthy? Who defines healthy?
An insurance carrier. Well, let's see. So the ones that I have, because I've underwritten a lot of people, and typically if someone's on your basic blood pressure, they have no heart incident. They're not no heart disease, no diabetes, no lung issues. Even down to you can have a CPAP machine, but your rates will increase because that's still a risk. That's a health risk.
Yes.
So people that have passed underwriting either have no medications at all and no health incidents whatsoever. Some people have had no hospital stays. I've been able to underwrite a gentleman who was paying a high premium into a lower premium at 86 years old.
Wow.
He passed.
Yeah, that's awesome.
He passed. But, I say your general cocktail of Americans, which is your basic blood pressure, your basic cholesterol, and your basic intestinal medicine. Those are, that's the cocktail. Some may be sleep aid or something like that. That's not any high risk. So I look for, some of these carriers will provide a whole list of medications. if you have this medication, you get automatically denied.
Wow.
If I answer yes to some of these questions, because they're all electronic applications, if I answer yes, then it'll pop up, this person does not qualify.
Wow.
So it's iffy. So that's why I do a screening first and let them talk about their health. We kind of dig into it, what have they had in the last year? And sometimes people think that they've had a hospital stay and it was no big deal. But I'm like, oh, well, it's going to count against you, and sometimes maybe it doesn't. Even people now I've been able to have people get a pass even if they've had cancer, but a long time ago. Sometimes more than 5 or 10 years ago. They fully recovered.
And my understanding, too, is in some of these people, in one of your previous podcasts, you and a guest were speaking about someone being in the hospital for a prolonged period of time, I believe. And normally under traditional Medicare, you don't have to worry about that. It's covered. But my understanding is the replacement policies put like certain days. Like if you're in the hospital over a certain number of days, your cost increases.
Not
out of pocket?
Not necessarily.
Okay.
So let me explain that. So you have, on every Advantage plan, there are co-pays in the hospital per day.
Okay.
A lot of them will go either per like 4 days on the 4 days up to 7 days. And so that's how many days you will pay that copay. If you stay beyond that limit of days, okay, then your costs are all covered. That's if it's all approved.
Okay.
For you to stay there, then you have no cost after that. So like I pair this with an indemnity plan, so it's like they can file a claim with that and I set it at the amount of their Advantage plan so that they can file a claim on this extra policy and get reimbursed.
But the patient has to file that claim, correct?
Yes.
The hospital can't file it. So it's not.
No, it's not really insurance. It's a policy, but it's an indemnity, so they'll get cash back.
Yeah. And you cannot get a supplement on an Advantage plan.
No, you cannot have both.
Yeah. So you have to still pay that out of pocket. You're responsible for that out of pocket. Okay.
So when you're educating about getting on an Advantage plan, you educate to that total max out of pocket. In this area on a PPO, it can be anywhere from $6,700 all in network or in a combined in and out of network to $10,000 and beyond. I've seen them go as high as $14,000. So that's what you need to say is in a catastrophic event, then that's what you're going to, that's real. Think about that picture, though, of health. That's really, really sick. Dialysis.
That's what we see.
Cancer.
That's what I see on a daily basis. Yeah.
So let me paint. I had another client that lived on an Advantage plan since I had him in 2017, and he went through cancer 3 times. And his plan with this certain carrier was pulled from the market during the annual enrollment period, meaning they were not going to sell it anymore. That is someone's golden ticket to get back to original Medicare from an Advantage plan, being unhealthy with no health questions asked. They get a letter from that carrier saying that basically, in so many words, this is your golden ticket. This is your golden opportunity. If you want to go back to original Medicare with the protection of the Medigap plan, you can do it. That's the only time, though.
Yeah. Wow. So you got to make sure they're ready to be on something for life.
And there's been a few instances where I have recommended that someone go back to original Medicare, and I knew they weren't going to qualify, but it has to do with their prognosis, where they were, and if I knew that they were going to get taken care of, and their out of pocket was going to be minimal. But it really had to do with their prognosis, their length of life.
Right, correct.
So that's the only time. But the annual enrollment period, just so y'all know, is October 15th through December the 7th.
Okay.
That is the time for people on original Medicare to change their drug plan.
Okay. Yes.
So when I was in home health, I had no clue why people really stopped taking their meds. because of the expense. We just referred him to the social worker and said, take care of this. Mrs. So-and-so's not taking her meds. And so, do something about it.
That requires a magic wand, fairy dust, and
Yes.
Rainbows.
Yes. I did not know it was their drug plan when I was in, treating patients out. And now I know that. And so I didn't know, and they didn't know at the time, that you could change your drug plan during the annual enrollment period. And some people that get on Medicare don't even realize that drug plans change every year.
That is some good information, because we do have some people who have some issues that have been brought up about medication payments. So
Yeah.
Yep.
that's
And
very
so
helpful.
maybe initially they were put on the wrong drug plan. Drug plans need to be evaluated every year.
And just speaking from experience and helping my dad get a drug plan, it's overwhelming. And I feel like I have a smidge of understanding.
I could teach you how to, Medicare.gov, I have my little tools that connect to that, and they're similar, but Medicare.gov, I've used it for years. And I think it has a really good drug analysis tool. But I could teach you in probably 30 minutes how to analyze those drug plans. You already really, truly have the knowledge being in healthcare.
Right.
You just you need to know how to portray it. So Medicare.gov makes it available for everyone, but they don't know how to read it.
Right. And that's what I think. Because, if I'm looking at it going, oh my goodness, but
It's
figure it
overwhelming.
out. But it is overwhelming. And I know for me, if I get overwhelmed, I'm walking away. I'm
Me
going to
too.
mess with it.
Yep, not going to do it.
But yeah,
But yeah, I can.
could help
And-
people.
Drug plans, that's part D. D for drugs. They don't pay, but there's barely any that pay us anymore. So for me, it's a service and a need that needs to be done. Because what if I have a client that comes in with 17 different meds? You think I'm going to leave them hanging,
Right.
knowing what's coming down the pike if they're not in the right drug plan? Even so. Speaking to drug plans, the total max out of pocket for someone to spend is $2,000 this year. Once they hit that cap, it's all zero.
Oh, okay.
So someone on real expensive meds, they'll hit that pretty, and that's what they pay. The drug plan pays, and then the manufacturer pay.
Right.
All has to equal $2,000 to get.
Something else too, I think that people don't understand is they think if they have traditional Medicare, everything's covered. Mom needs to go home and she needs a ramp put in.
No,
Why can't I get a ramp? Why can't I get a shower chair? Why can't I have the shower changed? Why can't I have the tub changed to a walk-in shower? Why can't they pay for that? They don't pay for grab bars. They don't. I think that's
No.
something else too that they don't understand. And we've even had issues with some of the Advantage plans getting equipment covered. Like I had someone who couldn't even get a walker because I was told the company gave them like a debit card for over-the-counter items.
they counted it as over the counter.
Yeah, they said this is for your Tylenol, this is for your cold medicine, and this is for you to buy the walker and the bedside commode. And the company was a particular type of there's so many insurances that they cover. There's
Carrier.
so many different carriers, and
yes.
within that carrier there's so many different plans. And whatever that particular plan was, I couldn't even get this patient a walker. So I had to send the family to try to go find a walker somewhere. And so I think that's another thing that people think I have Medicare, everything's going to be covered, and
Nope.
no, they don't understand that they can't have a ramp built or just get a wheelchair to have a wheelchair.
Right.
Yeah.
No, and it's on an Advantage plan, durable medical equipment is and DME, durable medical equipment companies, they're probably in the same boat as you guys. They fight too.
Oh, yeah.
I could have them on too, and it's a fight. But on those kind of plans, the 20% is what they owe. There's a 20% co-insurance on durable medical equipment.
Okay.
So again, people think that it's all covered. It's not covered. On the Advantage plan, they're going to have 20% co-insurance.
And I think even some of the equipment companies have given us specific sentences to say in our documentation to make sure the patient will qualify for it under that plan. Our professional recommendation and our regular notes on the quality of this patient's movement isn't enough. It has to say something very specific.
And that's another thing too, coming from a therapy, is the documentation. And so I've educated my clients on, that it's your therapist, your doctor, the whole clinical team has got to document appropriately to get things approved.
Yes.
I've lived that. It's probably worse now. I know it is.
Yeah.
Than when I was back in the home health days and even outpatient. I know it's gotten a little bit worse.
Yeah.
And the documentation and how specific you need to be.
Yes.
And how else are you going to learn that? They don't teach that to you.
They don't. They just deny, and we don't understand why we're getting denials. And then later on, the medical equipment company or someone higher up within the hospital system will say, "Oh, we figured this out. This is the words they want you to say." Because the people who are looking at this and giving the denials aren't medical professionals
No, they're
the most
following.
part.
For the most part, no, they're not.
They're
And
following the script. And if it doesn't say these specific things, they just give a denial. So that's frustrating as a therapist, being a professional doing this for 26 years. I know what my patient needs, and I'm trying to just get them what they need at the most basic level.
It's a game sometimes. It's a hard-fought game, and it's exhausting.
Yes.
If we could do everything for free and just treat the patient and never have to document, wouldn't that be nice?
Yes, it would.
It would be so nice just to really be the clinician that you
Yeah.
aspire to be. So just to treat them.
And I think going back to the rehab versus skilled nursing thing, I learned recently that the Advantage plans have started denying rehab based on the cost to them. My understanding is
Like inpatient rehab?
inpatient rehab. So one day in inpatient rehab costs around $1,000 a day, whereas one day at the skilled nursing facility is around $275 per day. So they've just automatically started denying, even if someone's had a major stroke, even if they've had a hip fracture. We've tried all the tricks. Jolene will have them, she'll submit stuff and set up where they do a doctor to doctor communication, where the doctors for the Advantage plan speak and then the hospital doctors speak. And it's still not working.
And I find it laughable with these Advantage plan physicians. They talk to my physicians who are seeing the patient, treating the patient,
Laid eyes on the patient,
laying
been
eyes
in the
on the
room with the
patient,
patient.
all the
Yes.
things, and they'll say they don't meet the Medicare criteria. Well,
Yes,
yeah,
there
they
is
do,
a-
because if they're traditional Medicare, we wouldn't be having this conversation. They do
Yeah.
meet Medicare criteria. It's infuriating, and then it makes it hard for the doctors to do what it's called a peer-to-peer. And they're like, why? Because, they're advocating for their patient. They're doing, the best they can to say they need this. I'm looking at them.
Have you ever laid eyes on the criteria?
I have. We had, it's been a while, but we got a denial, and they said they didn't meet Medicare criteria. It was an Advantage plan. And I went down the list. I'm like, meets. Like they did
So
meet.
how did they justify not meeting it? Because
I don't-
Advantage
I
plans
don't-
are supposed to cover what original Medicare covers.
Yeah,
That's
they're supposed to, but they don't.
Right.
And I don't know if their little check boxes are just, I don't know. They found loopholes, obviously, because
and you're not aware of the loopholes.
no, I mean, I don't know, what are these doctors? Are they doctors? Have they ever been at bedside? Do they have an understanding of the doctor that's speaking to them? I question those things, because if they did, and if they listened, they wouldn't deny the patient.
I had a conversation about all of this with the former medical director of a rehab here. And we had a full-out conversation on the denials that she gets. And she's taken me through what it's like to do a peer-to-peer review with an insurance company, in Medicare and the Medicare Advantage. And for her, I would just kind of let her pour out all of her frustration, because, I want to be able to fit a client with the right plan that, especially when I know they're going to need it later on down the road, with the right plan that's going to help them navigate the healthcare system with ease.
And I think that's the point you saying that to navigate the healthcare system, because yes, they're healthy now, but let's look at what could happen in 5 years. Yeah.
People don't want to talk about that, but it's
Yeah.
like, people don't want to talk about end of life either, or
Right.
the long-term care aspect, a component of needing that in your life, but it
Correct. 'Cause
you
the-
can't stop planning.
Because the Advantage plan doesn't cover long-term care. Yeah.
Well, neither does Medicare.
No.
Right. And people
Neither
don't
does
understand
Medicare.
that. Yeah.
Yeah, it doesn't either. So, in wrapping up, I know we've talked about a lot, but what would you say as a takeaway? So, if a beneficiary is listening to this, someone that is on Medicare or getting on Medicare, thinking about Medicare, what is a good takeaway from a healthcare perspective from either of y'all's departments, and the therapy and the patient care and then the navigation part of it to a beneficiary? What would you say?
So I would say educate yourself, but don't do it by yourself.
Very good.
You need to find
Very
someone
good.
who's very knowledgeable, because like I said, I've looked at a lot of things, and it's difficult to understand. It's difficult to navigate no matter how much you read. And like you said, you have a commercial or somebody calling you, giving you a shiny object. You think it's pretty and you're going to take it. So find somebody who can help with the education process and explain the things and the terms that are being said, because so many things are interchangeable. It can get confusing. Yeah.
It's like putting together. I found a joke. ChatGPT gave me a joke about Medicare. I've been searching for one for so long. And so I used it the other day with a big crowd that I spoke to, and it worked. They laughed. And so it was like Medicare is like putting together IKEA furniture without the instructions.
Oh, yeah.
Yes.
Yes, it is.
And they laughed. I thought, yes, I'll use that one again. Thanks, ChatGPT. But yes, I agree. Educate. What did you say again?
Educate yourself, but don't do it by yourself.
Very, very
Yeah,
good.
absolutely.
Very good. What about you, Jolene?
I think have the conversations. They're hard, but have the conversations. So
Have them early.
early, and so you don't get blindsided as an adult child. You're going to be involved in your parents' care, and you need to know all the things. I understand people try to be respectful, and you don't want to get in people's business, but this is something you're going to end up in their business when a catastrophic event happens,
Yep.
and you need to be educated. And if you're informed, then you make an informed decision.
I have sat many times with adult children during the annual enrollment period, their parents in a catastrophic event, and I know I can't change their plan. I know they just need to sit with someone that can explain the plan. And so I'm like, okay, put your cards out on the table. What does your parents have? I want to see their cards. Then I know what they have, and then I can go over the benefits in extreme detail with them. And I'm like, this is what you're dealing with. This is why it's happening right now. And this is what we can do or cannot do about it. And I think just having the proper education can give someone the security that they need. They know what's coming down the pike. I'd rather somebody know if they choose an Advantage plan, but they know what's coming down the pike. It's easier to handle that way. And I think it makes it easier on you as well, because they're not going to be so frustrated because they're expecting it, so to speak. But I could talk forever, and I'm sure we've missed some things. But, I just want to touch on this too. The annual enrollment drug plan changes
Okay.
and Advantage plan changes.
Okay.
And then the state of Texas, and y'all won't really have to deal with the supplement changes. All you guys are really concerned about is, can my patient get the care that they need on the plan that they have?
Yes.
Right.
So during the annual enrollment, they can change from Advantage plan to Advantage plan. No health questions asked. Remember, they'll be underwritten if they've been on Medicare for a while and they want to go back to original and get a supplement. And then that's also the time to change their drug plan.
Do you know, or have you found of any supplement plans that will approve inpatient rehab? Because we've had a hard time getting.
You mean supplement plans?
The Medicare Advantage plans. We've had trouble getting approval for inpatient rehab, so I don't know if there's a plan out there anymore that will even cover it now.
that I don't, there's not one carrier that just drops into my head, because they all kind of operate the same.
Yeah.
They all kind of operate the same.
Okay.
They're probably going to go towards the most cost effective for them, because how it works is that Medicare gives them, that insurance carrier, a budgeted amount of money each year to manage that person's health care, each individual. So it's their responsibility with that amount of money, so to speak, in simplest terms, is to manage that person's care and save the dollar. And so that's why probably you're getting denials in the, we all like rehab, because we were in rehab and we could do some really cool things in rehab and see the patient quite a bit. And skilled nursing isn't as intense therapy.
Yeah. There's still good therapists there, and it's still good therapy.
Oh, yeah.
It's just people typically want the more intense. And then we've seen more and more people on Advantage plans and less people on traditional Medicare.
Yes.
Yeah.
So the numbers are, I would say that they were probably neck and neck, but yes, there's a big push for that. And then in the end, some people regret their decision, because they don't really know what they're getting into. But yeah, those numbers, I will tell you, have never taken a dip down. Yeah. But, I would say that they're pretty neck and neck, supplements and Advantage plans. But yes, you do see a lot of changeover during the annual enrollment. But I tell even my clients, I'm like, if you ever want to switch to an Advantage plan, you're going to sit with me face to face. We're going to have a conversation, and we're going to do the education all over again. And then I'll let you make up your mind, But it does come with a lot of education. And when someone calls those numbers on TV, you're getting a salesperson. And yes, they do read a script. Yep. They're in big call centers. Now, I've got some really good friends in the industry that have call centers, but they do it right. And I know, and they do both sets of plans, but they do it right. They do with education. Education first, serve first, sell second.
Good.
It's kind of what I do it. So educate yourself. That's probably the biggest takeaway. But not by yourself. Yes. I like that, Tony. That's like my new motto. Okay. I'm going to T-shirt now that say it. So anyway, thank you guys for coming, and thank all of you for listening. And that's another episode of the Morgan Medicare Minute.